weighted imaging diagnosis of malignant breast lesions and post-operative follow-up by Dr. Suzanne.
Today we're going to talk about maybe the main topic of the lecture is the role of diffusion MRI, diffusion weighted image in the diagnosis and follow-up of breast cancer. But I'm not specifying the whole lecture for the diffusion. I'm just gonna give a general hint about the MRI in breast imaging. First of all, I would like to thank all the attendants and Professor Mohammed Al-Huda, Professor Wahid Tantawi, and Professor Khalid for their amazing effort they've done for creating such a place. And we shall start with the anatomy, which is the basic of everything. As far as we know, the breast is a modified apocrine gland, sweat gland, that is specified for secreting milk. It has a functional purpose, and it's mainly formed of three main structures: the glandular tissue, the fat in between, and the fibrous network that's supporting them. I'm not going into too much details because it's a very long topic, but we should know how is it composed of. It's composed of about 15 to 20 lobules. Each lobule of the glandular tissue is formed of each loop formed of hundreds of lobules, and each lobule is formed of much of the histological unit, which is the terminal duct lobular unit. This is the histological unit, and it's formed of multiple of intralobular and extralobular terminal ducts, and each end into the blind end of acini. Very important thing to know about all the blood vessels or whatever, or the nervous system, it's about the lymph drainage, because it's the primary way of metastasis in breast cancer. And as far as we know, most of the lymphatic drainage of the breast goes to the axillary lymph nodes, and in current classification, it's just classified into 3 levels, not the old groups, apical, anterior, posterior, and it just classified according to its relation to the pectoralis minor muscles, being level number 1 medial, level number 2 behind the pectoralis, and level 3 just lateral to it. Also, the internal mammary lymph nodes, mediastinal lymph nodes, and para-aortic lymph nodes, superior and inferior epigastric, all share in the drainage with a much lesser percentage. Rapidly moving to the MR anatomy, which is the basic of our topic. As we see, what is the advantage of breast MRI above all? It's just that it has very anatomical imaging technique that I can really see much more details than I can see with conventional mammography or ultrasound. Here I can clearly identify, Here I can clearly identify the skin, and this is a T1 image. Okay, the fat and high signal. We have the glandular tissue. It's in low signal in both T1 and T2. We can see posteriorly even the muscles, the ribs, the thoracic cage, and even part of the lung posterior. This is very important to detect the extensions of our lesion. Here are another pictures to illustrate the anatomy. I have here T1 image, but after fat saturations and contrast with administrative, and this is a T2 weighted image. We can here clearly see the fat, which is here inhibited or saturated, and can be seen in T2 sequence. The glandular tissue, which has become here more hyper-intense because of the contrast administrated, and it's still hyper-intense in the T2. As we said before, we can also identify the retro-mammary fat and the muscles, the chest walls, and so much many details. So I just wanted to say something here about the anatomy, about the physiology of the breast. In normal breast, the normal breast tissue takes faint, gradual enhancement it's not enhancing usually. As we administer contrast, it just gradually become more and more hyper intense, and we know it's the rising curve, as we know. This is very important for one thing. After the second week of menstrual cycle and the third and fourth, there is much activity in the mammary gland, and this makes the enhancement much more prominent. This is important to know because in cancer or in lesions, I need to know the pattern of enhancement. So I cannot just risk doing it in the fourth week or something to mix both lesions. So I prefer always to do the MRI for breast imaging in the second week. From day 7 to day 14. So I can just somehow ignore the high signal or the rising signal from the normal enhancing glandular tissue. Another just details about MR anatomy, we may find sometimes enhancing structures here, maybe linear, maybe nodular. We should not miss this for, we should not misinterpret this for lesions. This is just simply vessels, and we can see it in T2 sequences as phlovoid. And this is somehow a rounded lesion, yet I can see clearly the fat sinus. This is just an intramammary lymph node, nothing more. So, just briefly, what is the pathology of breast cancer? I'm just here specifying the cancer and not the lesions in general. Before I'm just gonna talk about some risk factors, and we have to know one thing. The most important risk factor in breast cancer is just being a female. 50% of females who have breast cancer, they don't have any risk factor other than being just a female. Yet some risk factors, other risk factors are also present, like the age, the older the age, the more the percentage, yet in younger populations, it's really very aggressive with short survival. Genetics like BRCA1, BRCA2 genes and mutations, the family history like blood relatives, especially first degree, sister, mother, and daughter. The personal history of some cancers like colon or uterine or previous contralateral or ipsilateral cancer, breast. The nullipara female, because it's always under the effect of estrogen. The menstrual history, early menarche and late menopause, it's all about just the prolonged duration of estrogen. Hormonal replacement therapy, again, and ionizing radiation to chest, like in cases of lymphoma or otherwise. Obesity is another risk factor that I would like to talk about, because it just, as we know, obesity means more fat, more estrogen storage, and that's another risk. And this is something that we can modify. So, briefly, the malignant lesions are just classified into stromal, epithelial, and others. As far as we know, epithelial tumors are the most common, being either non-invasive or invasive, and the most common ever is the invasive ductal carcinoma. Other types like invasive lobular carcinoma and as much as we like to diagnose early the ductal carcinoma or lobular carcinoma in situ, this is much less frequent, yet why should we know the classification of these lesions? We will not ever say a mammography or MRI breast and say this is invasive lobular carcinoma, or this is, we don't say histopathology, but we have to know, because each pathology has a specific pattern of appearance, enhancement, and it's very important to know when and how to suspect these lesions. Stromal tumors like keloid tumor, liposarcoma, fibrosarcoma, and others like lymphoma and metastasis, as far as we know, most common metastasis to the breast or lymphoma and malignant melanoma, and also skin tumors. The way of spread, most important, would be the lymphatic and most common, also direct extension to the chest wall, and hematogenous, with the most common site is the bone, as we know. For breast cancer, we have many ways for staging. Most prominent is the T&M, so we can eventually reach a stage where we can say for stage 1 or 2 they could be resected, operable, and 3 and 4 are non-operable. It doesn't mean there is no hope. We shall wait and see for that. So, from the basic, what does it mean, or how do we do the dynamic contrast enhanced MRI of the breast? We're going to talk for a while about the technique. This is very important because it's a very special examination. As we said before, we do it in a normal menstruating woman in day from 7 to 14, as we said before, to avoid the unnecessary enhancement of the glandular tissue after then. In patient taking hormonal replacement therapy, we should stop it, the hormonal replacement therapy, 2 or 3 months to avoid the unnecessary enhancement as well. In patients who had radiotherapy before, we should delay it for 9 months, as we know the changes after the radiotherapy, like the inflammatory changes, may mask much of the lesions. Yet, if there is a patient that is diagnosed with breast cancer by any means, and she's going to have MRI breast, or even like staging diagnosis, searching for bilaterality or something, just ignore the timing totally. She needs to do it right now. Also in pregnancy, it's preferred to avoid the first trimester, as there is not much data about that, or the safety. Field strength, we usually use the 1.5 Tesla, this is much known. 3 Tesla is developing with much more challenges we have. I'm not going to talk much about it because it's much more physics. We use the phased coil, the coils, the phased array, or the surface coil. We prefer the state-of-art coil or the phased array, which is clarified here, the first photo. We just have this hardware, this coil, and we have 2 sides, places for the breast to hang in. It's very nice, like closed coil, it's very specified. And the other option is the surface coil. It's usually used for patients who cannot lie prone. So what about, we can decide if we have lesion in one side of the breast, which I choose to do, unilateral imaging or bilateral. You cannot ignore that. Unilateral imaging has the advantage of I'm having small field of view, so I can give better spatial resolution. I give better photos, much better, yet we cannot ignore that. Very high percentage of breast cancers may be found bilateral. It's like maybe up to 70% may have focus in the other breast, and like 30% have another focus in the same breast. So we usually prefer to do it bilateral, even not just for searching for lesions, even for comparison. Like if we're having enhancing area, we can really determine if it's important or not, because usually symmetrical enhancing areas are usually of benign etiology. The position, which is very important, we should inform the lady undergoing this investigation that it's going to take a specific time. She's going to lie prone with her breast hanging in these coils. We should offer her pillow to comfort her arms and head, and we should put the cannula. And we're talking about the contrast agent. Normally, there is no MRI breast imaging without contrast injection, except maybe in females first trimester, or if they are contraindicated with contrast agent in general, like grade 4 or 5 nephropathy. So we know that the gadolinium-based low molecular weight agents is our best, and we do it as single dose, 0.1 or 0.2. There is no much difference for the cost. We prefer 0.1 millimole per kg body weight with a rate of 1 to 2 milliliters per second. How we would choose our imaging technique. So what should we concentrate on? The spatial or the temporal resolution? This is a very important item. Still, above all, the morphological characteristic of the lesion is my first one priority. If my curve, or if my signal intensity curve says that this looks like benign lesions, but my morphology says it's a malignant, then it's a malignant. That's why we need very high spatial resolution. Yet, in injecting the contrast, we need to do dynamic phases, as we know that malignant lesions usually take rapid wash in and rapid wash out. So how we do, just figure this out. We usually prefer to start the first image and last image of our technique with slow timing, very high spatial resolution images, and in between, especially the first and second images after the contrast injection to be very rapid with high temporal resolution, so we can just detect the changes in the contrast. The imaging plan is also important. We usually know in breast we do it the planes according to its axis. This is axial images for the breast, and it's very nice for comparison and anatomical. Also, if we're doing it coronal, it's going to be nice. Sagittal imaging are more natural, and we use small field of view, so we get two benefits. We have high spatial resolution, and same time for the small field of view we get good speed in imaging. So we have, I'm having to do too much sections to cover the whole breast or the bilateral imaging. Pulse sequences, we do two things, T2 and T1 with multiple phases. T2 is usually it detects the water-containing lesion, as we know, like cyst or something, and it's said that if the lesion is high in T2, it means it has too much water, then very weak chance to be a malignant lesion. There is no cell banking here. The T1 we do it before contrast and at least 4 times after contrast administration, so we can detect it. Yet, as we know, if I gave contrast and if enhanced the lesion, it just will become as much as like the fat, surrounding fat. This gives us the other step, which is the fat suppression. And here I have two choices, either to choose a sequence that would suppress fat completely, or I would do subtraction. It's really preferred to do subtraction, although it may be affected by patient motion, but subtraction just highlights the enhancing lesions. If a lesion is not enhancing, it's not going to appear, and this is somehow a reliable sign of lack of malignancy here. So we prepare subtraction, as we said, and then we start with the image post-processing. After we do the subtraction, we start to see our region of interest and start doing the signal intensity to time curve, or even something like maximal intensity projections. All these post-processing methods will help us. And then, this is the most important part here. I've done the MRI press and I got a lesion. How can I analyze the lesion? First of all, we just split it into 3 major categories as morphology. We will assess in 2 ways, morphology and the enhancement pattern and signal intensity curve. The morphology, we have 1 of 3 according to the ACR. 1 of 3 types of lesion. MS, which is space-occupying lesion, can be appreciated in pre- and post-contrast images. And if we had a mass, we should assess it in each single way we know, like the margins, the appearance, the pattern of enhancement, peripheral and central. This is very important. The other thing, and if we have an example here for that, this was proven to be invasive ductal carcinoma. We have here, we can see the speculate, somehow the irregular margins, the high signal somehow, and the cursor here, this is the lesion we talk about, and here the cursor is just incidental finding of another focus of the tumor in the same breast, as we said before. Number 2 is the non-mass-like enhancing area, and this is very important, but this is much beyond the capacity of the mammography. That's why it's very important to do MRI in suspecting such cases, because this is a case histologically proven to be invasive lobular carcinoma. And I will return again to say that invasive lobular carcinoma has the characteristics of being just branching and infiltrating malignant cells throughout the breast. It usually doesn't cause a mass. So we cannot see a mass. We cannot see a mass in the mammography. We cannot see a mass in the ultrasound. Here, We may even, without contrast, just ignore it. And just here, after contrast administration, we can really see that we have this non-mass light enhancing area. It may be not appreciated in pre-contrast images at all. And this is very important to detect. Invasive locular carcinoma has also the characteristic of being usually bilateral, multicentric, multifocal, and it's really somehow aggressive in a very much way. The third component, or the third lesion type of lesion, is the focus. The focus is just very small, less than 5 millimeters lesion that is too small to characterize. It may be anything. The spectrum may include from just a small cyst to invasive, early invasive carcinoma. So we should not ignore, we should mention, and we should at least put for follow-up or use the other characteristics of malignant lesions if we have. This is very important to satisfy the first part of the BI-RADS in MRI imaging. Also, MRI imaging has BI-RADS classifications, and first of all, we depend on the morphology. So we characterize the lesions qualitative, as we said, and quantitative. That's how we put the region of interest in, on the lesion we need, and then before and after contrast images, we get our time intensity curves. This is a very good example for many things I said. We can see here two enhancing structures. We have this, we can say diffuse or non-mass light enhancing area, and we have this. This is just like 60 or 90 seconds after injection and up to 4 minutes. We will have a very good notice here that look at this lesion. As we go more late in time, it increases in enhancement. While this lesion just starts the enhancement to fade away. This is just a normal enhancing mammary tissue, as we said before. This is just normal, and it increases by time, as we said. And this is somehow it presents the curve of malignant lesions with other characteristics as well. We get one of three curves, type 1, type 2, 3, with increasing risk of malignancy here. This goes more with the more benign lesions, and it we call rising curve. We just add the C, for example, the normal mammary tissue or any benign lesion, it just takes the contrast gradually and increases by time. The plateau has somehow significant risk for malignancy, and it just starts with contrast enhancement and then go in a plateau phase. Type 3 has a very high percentage of being malignant. This lesion, it consists, like most of the lesions we know, early wash in and gradual wash out. This is so much part for the contrast enhanced MRI is enough, and we're going to talk about the diffusion shortly. What is the diffusion? To simplify things for even younger participants, the whole idea is that normally I have my water molecules that can move freely between cells in the extracellular space. It can move freely if I'm just having normal cells here with normal count. So there is no restriction for its diffusion or for its movement. Yet, if we are having many cells, cell packing, as we said in case of tumor, there will not be much space for molecules to move here and here. So it's going to have restricted movement. And that's the thing that we can detect. Also, for just knowledge, we have another type for, or another cause for restricted diffusion, which is if the cell itself is swollen in case of inflammatory changes or whatever, the water molecules cannot move within the cell. So, what is the idea of diffusion weighted image? I'm just using imaging modality or sequences to reflect the microstructural environment we have as we go to the water. It just reflects to us if there is too much cells within this place or not. Cell packing just goes with malignancy, and that's it. Two things we have to know. What is the B value? it's very well known that we take the diffusion weighted image. It's kind of T2 weighted images, but with p-values. What is the p-value? The p-value is, as we said, the strength of the diffusion sensitizing gradient. It's just an equation that have many factors that gives us at the end something for p-value. This p-value is very important. It's just the whole idea that we see through it if the molecules are really restricted or they can, at high p-value, just diffuse. So, to have the diffusion weighted image, we have to do at least 2 p-values. One of them is 0, the normal T2 images, as we know, and one of them is high p-value ranging from 500 to 1000. When we do each, we have our indications. For example, sometimes the carcinoma in situ and the fibrocystic disease both show restricted diffusion. Because carcinoma in situ doesn't have much cells, and also the fibrocystic disease. So, as much as we raise the p-value, the carcinoma in situ still have their signal, their restricted diffusion, while the fibrocystic disease would lose it. This is a very good thing to characterize. So, we cannot rely on something subjective or qualitative. We have to have a value for that. For not everything that have restricted diffusion express too much cellular packing for malignant tumor. So, the ADC is just somehow the subtraction of the diffusion images, and it reflects how much there is restricted diffusion within these areas. As we know, the ADC map usually is the negative algorithm of the diffusion weighted image. If a lesion is really restricted diffusion in the diffusion weighted image, it will just appear dark in the ADC map. Yet it just pride in the diffusion weighted image and pride in the ADC map, we wouldn't consider it as diffusion restriction, and it's just what we call T2 shine through. So, if it's the negative algorithm, we have just to know, we just realized that the more restricted diffusion, the more or the lower the ADC value. And this is very important for the coming talks. Timing, we're just gonna explain on this. After all, we're gonna do it in week 2. So what is the dilemma about week 4 in the menstrual cycle? It's just that I need high ADC value in breast tissues, so I can, if there's a lesion with low ADC value, I just can easily detect. The breast contain much water as possible in week 4 or few days, reach the peak few days after menstrual cycle. So I have diffuse ADC, high ADC value or no restricted diffusion, as we say. Yet we return to the dilemma we said before about the enhancement, if you remember. I don't need unnecessary enhancement in the breast tissue. So we just keep it with week 2, and there is no much difference except like 5.5% in the ADC value between different phases. Post-processing include, as we return again, we'll start by our conventional imaging, assessing the morphology. Then we'll do the dynamic contrast enhanced MRI, get our lesion identified and get our curve, and then put the region of interest in the center of the lesion. We start with contrast enhancement to delineate the lesion, as we know, and then finally we get our ADC map. Although it's promising, it's not really faultless. It has some technical limitations, of course. Some are just can be overcome, like the air surrounding or something, and others still we are doing our best to overcome it, like the microperfusion. The ADC value is not just affected by the Brownian motion, but also by the microperfusion. So it makes the ADC value higher than it should be. That's why we may use more high B value. If we use more high B value, we will just ignore the effect of microperfusion. Another limitation is the small lesions, like the focus we said before. I cannot put a reliable ROI on such a lesion. Also, the malignant lesions with central necrosis, maybe just there's a very thin rim of enhancing tissue out there that I cannot put ROI that I would consider reliable. So finally, what are the applications of diffusion-weighted imaging? And after then, I will tell the general applications or indications for the MRI breast imaging. First of all, and our main topic is just, we're trying to differentiate between benign and malignant lesions. We don't need much biopsies as was done these days. So, we have an ADC cut value, as we said before, not every lesion restricted diffusion should have, should be a malignant lesion. We had, it was just known that 1.13 is a reliable, somehow cut off value, plus or minus a few changes. For example, we have these lesions with high ADC value. We can see here multiple lesions of restricted diffusion. And if we did the ADC map, we would just find it restricted diffusion, yes, yet the value of it was about 1.5. This was just bilateral hyperadenoma. Also, we have to know that the bilaterality, multiplicity, something else is reassured. For lesions with low ADC value, we can see here, this is lesions, enhancing lesion that has restricted diffusion, and in the ADC map it was found to be like 0.6. This was invasive ductal carcinoma, histologically proven, and this is a good example for this. But it's not always that easy. It would be like a magic if we said this is cut value is just like a magic, we know malignant or benign. No, we have some limitations still here. For example, the carcinoma in situ, as we said before, doesn't have much cells, so it wouldn't give me a very low ADC value, as we know. So we may overcome it, as we said before, by increasing the B value as much as we can. It may be helpful. Yet some other lesions like mucinous carcinoma, it's just, you know, it's from histology, it's just about abundance of matrix and few cells in between. There is no way there is restricted diffusion here, and we can do nothing about it. Some benign tumors may have low ADC value, like if the fibroadenoma have too much fibrous component. Inflammatory changes as well, as we said before, it's another way for restricted diffusion within the cells this time. And intraductal adenoma. This is a very challenging or a problematic lesion, because it's sad that adenoma cannot be reliably differentiated if it's benign or malignant on normal MRI, just conventional MRI, dynamic contrast MRI, or even diffusion. It's really dilemma, this little problem. Other applications, and it's very reliable this time. We can differentiate between recurrence versus surgical scar. For all who practice mammography, we know that the surgical scar is a very hard thing to differentiate from recurrence. Yet, using the diffusion-weighted image, I can just detect if it's fibrous tissue or it's just scar. It wouldn't have restricted diffusion, as we agree. If it's malignancy, we're back to what we said before. We will have enhancement on enhancing sequences, and we will have restricted diffusion in a very sufficient way to differentiate. This is my most favorite, actually, because as we said before, indication. As we said before, breast cancer could be staged in 1 and 2, stages 3 and 4, which 4 we consider completely unresectable or non-operable, but somehow there is hope now. As we know, they started to give chemotherapy, neoadjuvant chemotherapy for newly diagnosed large lesions, and we just wait for the response. It may downstage the tumor and render it from non-resectable to resectable, and this is very hopeful. We have 2 examples. Number A, this is fortunately a very good response. The point is, I cannot just detect it, I can detect it very early, in a short duration, as short as like 4 to 5 days. It's not like it's very hard to assess response after chemotherapy into mammography or ultrasound. It's not very reliable due to the changes, but here, just before we complete one course, we can determine that it started to lose diffusion. There is much apoptosis here and cell death. I'm having the good faith here. Unfortunately, another example, yet I don't have much difference, like less than 5% in the diffusion restriction. It wasn't responding to chemotherapy. The last two indications are evaluation of the peritumoral tissue. We can somehow detect the surgical margin, as we say. We can just start by lesion, very restricted diffusion in the middle, and then we start the restricted diffusion decrease gradually till the transitional zone where it's somehow restricted, and then we get to normal tissue. Here I can delineate the area around the tumor that have restricted diffusion and potentially have invasions from the tumor cell. Also, the assessment of axillary lymph nodes, which is very important for staging. I wouldn't depend only on the ultrasound or whatever, or the sentinel mapping, so we can use also MRI. In all this, MRI is a very good and somehow very sensitive way to detect or suspect malignancy in non-invasive technique. We don't need much biopsies as done these days. It doesn't just compromise the patient's life or shape or whatever, even cosmosis. It just also makes detection of the lesions later, like MRI after biopsy should be delayed for 6 months. Why don't we start by the MRI to detect as much as we can? Gladly, these illustrative cases, they are few, but they were done here at this MRI machine we have inside there, and with the help of Dr. Caleb. He was very supportive in making me get these cases. And shortly, there are just 3, I know I'm too long. This is a 57-year-old woman with lung nodule, metastasis or something, and we're searching for primary. It's an indication. It's a very important indication for MRI. Ultrasonography was inconclusive. What we can see here, and we see here from these different stages, including the T1 post-contrast, subtraction, and the diffusion, that there is MS. And it has malignant criteria, and it has restricted diffusion. It was histologically proven to be invasive ductal carcinoma. Case 3 is a good example for pregnant women, as we said. Some people may say we just may use dynamic contrast enhanced. Maybe in pregnant patients we cannot use contrast. So we can just do it as conventional and diffusion. In this patient, we can see just the asymmetry and prominent glandular tissues, and there is this irregular speculated lesion, retroareolar, that's seen in stair images, and it has restricted diffusion. It was the value of 1. It's very highly suspicious, at least categorized as by RADS 4C, something like that. We wouldn't have before be able to detect such lesions in lactating or in pregnant women, as we know it's too much dense breast tissue. The final case is known case of breast cancer. On the right side, underwent reconstructive surgery. It just made lumpectomy, and we're searching for it. Just had some changes here. I'm not sure if this recurrence, scar, inflammation, postoperative changes. So MRI T2 images, we can see multiple high intensity lesions, just areas of high intensity. Let's see what the contrast says. It's just a lesion with peripheral enhancement, and it's even reaching the anterior chest wall. Let's move to the diffusion. It was of value up to restricted, yes, inflammatory changes, but the ADC value was 2, and this was reliably diagnosed as postoperative inflammatory changes. So conclusion, briefly. Diffusion-weighted image is a promising sequence that can detect changes in the microenvironment of breast tissues without significantly increasing examination time. Diffusion-restricted lesions can be detected on diffusion ascribed signal. Calculating its ADC value helps to determine the diffusion restriction on non-subjective basis. As we said, it's something quantitative. So the use of diffusion-weighted image as diagnostic tool may increase the specificity, and I say even the sensitivity more, of breast MRI to detect malignant lesions, evaluate the effect of chemotherapy, and reduce number of false positive results and associated anesthetic biopsy.